Welcome to this satellite symposium presented by Eurofins Transplant Diagnostics, combining blood gene expression biomarkers and donor-derived cell-free DNA. Our moderator for today's session is Patty West-Thielke, Senior Director of Medical Affairs at Eurofins. Our speaker for the session is John Friedewald from Northwestern University. Joining Dr. Friedewald for the live Q&A will be Michael Germain from Bay State Health. Please stay tuned after the session talks for the panel discussion. If you would like to submit a question directly to the session moderators, please utilize the Q&A feature on the side panel of your screen. Enjoy the session.
Good morning, everybody, and thank you for joining today's breakfast symposium as part of the Cutting Edge of Transplant meeting. My name is Patty West-Thielke, and I am the Senior Medical Director at Transplant Genomics. Oddly, I just attended the Live Controversies Conference in Breckenridge, and I really wish we could all be together for CIAT this year. But I know we are very much looking forward to seeing each other at the ATC in Boston. Transplant Genomics is very excited to be able to be part of the CIAT meeting and offer this exciting presentation. Early experiences with a novel biomarker panel for detecting kidney transplant rejection. Our speaker today is Dr. John Friedewald. Dr. Friedewald is a professor of medicine and surgery at the Northwestern University Feinberg School of Medicine in the Division of Nephrology and the Comprehensive Transplant Center. He is the medical director of kidney and pancreas transplantation at Northwestern Memorial Hospital. And Dr. Friedewald is a fellow of the American Society of Nephrology, American Society of Transplantation, and the American College of Physicians. We will open this up for Q&A after the presentation. Please feel free to enter your questions into the chat during the presentation so we are ready to start a lively discussion. Thank you again for joining our presentation.
Hi, I'm John Friedewald. I'm a transplant nephrologist at Northwestern University in Chicago. I'm going to talk to you today about some work we've done trying to combine blood gene expression biomarkers with donor-derived cell-free DNA to better monitor our kidney transplant patients. Before we dive into the biomarkers, I want to set the stage a little bit about who we want to monitor and when we want to monitor them. We refer to that as the context of use of a biomarker. This graphic here shows the life of a transplant patient, and in particular, you can see the time of transplant here with time going forward to the right. What we want to prevent is this chronic injury and fibrosis that happens in kidneys over time. And we've learned through multiple studies now, doing surveillance biopsies, that there's a lot of inflammation that can occur early in the life of the allograft, that if we prevent, hopefully, we can prevent this chronic injury and prolong graft life. What we know is that by monitoring only GFR or serum creatinine, by the time the GFR starts to fall, it's too late. You have irreversible fibrosis in the kidney in most cases. And so what we want to focus on is this early inflammation that presents. Now, if we do clinical trials like we've done using surveillance biopsies, we find that in about a third of patients, there's ongoing and persistent inflammation in the graft that's undetected by serum creatinine. And so only surveillance biopsies previously could detect this. Now, occasionally that inflammation gets more severe, and we have an episode of what we call clinical acute rejection. And that's often detected by a for-cause biopsy. But again, you're waiting on the serum creatinine to change and not being proactive and monitoring for this subclinical inflammation, which can cause a lot of graft injury, fibrosis, donor-specific antibodies, and worsened graft survival. So this is where we want to focus our efforts. Another way to think about this graphically is shown here. We can detect subclinical inflammation in its early stages when it's not burning the whole house up, and that's when we want to try to intervene. That can progress to subclinical rejection, again, limited in parts of the kidney's still working fine, but that again, we want to detect that before we miss the boat and get to clinical acute rejection where the whole house is on fire. So again, using non-invasive methods rather than surveillance biopsies, we want to try to monitor our patients for early inflammation and prevent that successfully from happening. So how do we do that? Well, we talked about the two different technologies, and I get a lot of questions about how are these different? Aren't they the same? Aren't they molecular tests? And the answer is they are different, and we're going to talk about the difference between a gene expression profile biomarker and cell-free DNA biomarkers. So starting with gene expression tests, how do we develop these tests? Well, in our case, we did a clinical trial called CTOT-08. There have been others just like it developing similar gene expression tests. We followed 300 patients from 5 U.S. transplant centers for 2 years, doing surveillance biopsies, and then we collected serum samples and blood samples and urine samples, et cetera, and we're able to go back afterwards and cluster groups. So we had patients that had subclinical rejection, meaning a biopsy showing rejection in a stable patient. And then we had those that had stable function and had normal biopsies. And we can take the two different groups, do peripheral blood gene expression profiling using an Affymetrix, a whole exome array in this case. We then get 30,000 genes where we have to then filter using a bioinformatics pipeline, in this case a random forest model, which asks the question, how can we boil down the genes to the lowest number that help tell these two groups apart? And in this case, it ended up being 120 genes that are in the TrueGraph gene expression classifier, and that's shown here, that are up or down regulated between the two groups, that can help us tell apart patients who have control or normal biopsies versus those that had acute rejection with stable function. And that's how these tests are developed. So again, these tests are trained on two different disease states, no rejection versus rejection. And then that was our discovery and validation, initial validation cohort. Has now been validated in other external cohorts. And this is just one example of a 7 transplant center study that validated the TrueGraph gene expression classifier, monitoring stable patients. And what we found initially is that this was a rule-out test, meaning it had a high negative predictive value, around 90%, meaning that if you have a negative test, which is a TX, or transplant excellent result, as it's called, that gives you a 90% certainty that there is, if you did a biopsy, you would find no rejection. Now, the idea is for centers that do surveillance biopsies to be able to avoid a surveillance biopsy in patients with a negative result. And that's the way we've used it here at Northwestern. The positive predictive value was closer to 50%. And what that means is you get a positive result. You're not certain there's rejection, but you do want to pay a lot closer attention to that patient. In our case, we usually just proceed with the biopsy we would have done anyway, but we're able to avoid the biopsy in about 2/3 of our patients who have the negative results. So this is a way to sort your patients and manage them better in terms of how to do surveillance for subclinical rejection. Now, what's cell-free DNA? This is a DNA that's released from cells after there's injury or death into the circulation. You can measure that. We leverage the fact that we have a genetically distinct organism, this kidney inside of a person, and that's going to release DNA from the donor that's going to be slightly different from the DNA of the recipient, assuming they're not identical twins. And you can tell that difference, and then you can quantify the amount of DNA from the donor compared to that of the recipient and look at that ratio. That's the percent of donor-derived cell-free DNA. And the theory is as the graft is injured, it'll release more DNA from the donor, and that donor-derived fraction is going to increase. And so that's the way this test is used. Now, that's not really specific to a disease or etiology. If you think about the way the gene expression classifier, we took 2 disease states and then developed a test based on that. This is a test that is a non-specific marker of injury, and we've been studying it to figure out how best does it tell us about injury in the graft. And what we found, not our group but others as well, is that with increased study and use, we found that this is most sensitive to detecting microvascular injury as opposed to tubular or interstitial inflammation. Now remember, tubular and interstitial inflammation is the hallmark of cellular rejection, with the T cells, the target being the tubules and interstitium for T cells, versus antibody-mediated injury where the target is the vascular endothelium. So again, where do we see microvascular injury? Most commonly in antibody-mediated rejection. We also see it in more severe forms of cellular rejection where you have vascular injury. We also see it in thrombotic microangiopathies, cases of vasculitis. And so again, if you see elevated donor-derived cell-free DNA, now you can start thinking the pathophysiology is most likely microvascular inflammation, which is most commonly from antibody-mediated rejection. So donor-derived cell-free DNA has been used to detect rejection in patients with graft dysfunction. So publications I show you here in patients who had an elevated creatinine, had a biopsy for cause, and that's when they found elevated donor-derived cell-free DNA. But it really has never been, there's no published data supporting the use of cell-free DNA as a monitoring tool in stable patients. Even though it was marketed heavily for that indication, there really wasn't much data backing it up. So then we wanted to ask the question, can we look at this in stable patients? Well, we had a trial with a lot of patients with stable function and surveillance biopsies, which is really the gold standard. And that's what we did here. So we took patients from the CTOD trial and we said, okay, how does cell-free DNA work in stable patients is the first question. And then can we combine these 2 biomarkers to do better? So again, we took patients that had a surveillance biopsy. We had simultaneous blood gene expression using the TrueGraph assay and plasma donor-derived cell-free DNA using the TRAC assay. Of these 428 samples, 325 had no rejection, 103 had subclinical rejection, again, based on traditional histopathology. We then did the profiling and found what came up. So before we do that, let's talk about the rejection episodes. So the 103 rejections in the trial, you can see there was a mix. About roughly 1/3 were cellular rejection only. And remember, these are stable patients, so most of them were borderline rejections, some more severe. We had a category of suspicious AMR or AMR, about an even split, and this is pure AMR. Then we had a mix of cellular and AMR, and that's shown here in this group. Pardon for the sirens in the background. We do work at hospitals after all. And this is the results of the trial. So what we found was, and I'll start with the left-hand panel here, again, the 103 biopsies showing rejection, the 325 biopsies showing normal. And then this is the two tests. This is the track donor-derived cell-free DNA in blue, and the green is the gene expression profile, the TrueGraf assay. And we did this Venn diagram to show that although the tests have relatively similar performance, meaning detecting rejections versus no rejections, there was some overlap, but there was a lot of non-overlap, and that's what really caught our attention. So you can see here of the rejection episodes, 21 were positive with both tests, but 27 were only positive initially on the donor-derived cell-free DNA, and 23 were only positive with TrueGraf. So that caught our attention. So then we went to the right here and said, okay, let's look at the rejections and rejection types. And this is when we figured out or started to see this pattern emerging of the TrueGraf assay being better for cellular rejection and the donor-derived cell-free DNA being better for antibody-mediated rejection. So if you look at the three categories I showed you before, here are the cellular rejection alone in this quadrant here. And you can see the TrueGraf, the green, the TrueGraf picks up a lot of cellular rejections that the cell-free DNA does not. Conversely, over here, pure antibody-mediated rejections, you can see that the donor-derived cell-free DNA picked up more cases than the gene expression alone, and there were obviously some overlap. And then with both cellular and antibody-mediated rejections, both tests performed pretty well, and you see the overlap here. So again, we see that there is complementary nature of these two tests, one picking up more cellular rejections, one picking up more antibody-mediated rejections. And that was really the take-home for me from doing this exercise. And this is the publication, which came out in the fall in CJSON, and this just sort of puts everything together. Again, this was the CTOT-A trial with our surveillance biopsies. And this sort of aggregates all the data. So you can see the positive and negative predictive value of the tests. Again, both tests, the TrueGraf and TRAC cell-free DNA, have a higher negative predictive value than positive predictive value. But when you combine the tests together, you get a much higher positive predictive value if both are positive and a higher negative predictive value than either one alone. What we found is the gene expression was statistically better at detecting cellular rejection, and the cell-free DNA was statistically better than the gene expression at detecting antibody-mediated rejection. So again, two complementary tests working together. So what's happened since then? Well, there's been some technology evolutions in the back end, and this is just the evolution of the TrueGraf test. So I told you that this was a microarray test. Microarray is good at detecting differences in gene expression in terms of positive or negative here. You can see upregulated genes and downregulated genes, but it's not very good at detecting individual differences. So it's like playing piano with your fists. Here now, we've moved the TrueGraf gene expression test to a microfluidic PCR-based platform using the same set of 120 genes. And what we see now is you can better detect differences in individual genes, not just up or down regulation. What that allows us to do is be more sensitive and actually be better at predicting and detecting rejection. And so the technology evolution here was from the original TrueGraf microarray I showed you here now through TRAC alone as well, the TrueGraf and TRAC together on microarray, and now we're now doing the PCR-based test for TrueGraf, and when you combine the two tests on the new platform, you get a very high both positive and negative predictive value. So through some technology evolution over time, not only is the PCR a faster test, so you get quicker turnaround time, going from about 4 days to about a day and a half, but now we get better positive, negative predictive value on the tests when used together. And this is the OmniGraf test now combining TrueGraf and TRAC at the same time. And that's just shown here. So we have a higher positive predictive value. Primarily, the negative predictive value is fairly similar, slightly better, but a big improvement in positive predictive value when you do the two tests together. And the OmniGraf test is both tests now in one single blood draw that can both stabilize RNA and DNA at the same time in one report. So that's the technology and how we got here and how we discovered the tests. What I want to move on to now are a few case reviews that sort of demonstrate how you can use this in your own practice and how I think about when I get test results back. So the first case is a case of early subclinical cellular rejection recognizing and treating. So this is a 40-year-old woman with end-stage renal disease from glomerulonephritis. She had a first living donor kidney transplant, which was unfortunately complicated by an early graft thrombosis, and she was found to have antiphospholipid antibodies. She came back for a second transplant. She's now sensitized, had a living donor. Thankfully, there were no pre-transplant DSA, and she had a fairly uncomplicated transplant with all the anticoagulation and everything else. Now, of course, she's on chronic anticoagulation with warfarin, which she's been transitioned to for the APLS. And so this is someone you really don't want to do surveillance biopsies on. Remember, our practice at Northwestern was to do surveillance biopsies at 3, 12, and 24 months. You can see her serum creatinine. This is just a graph from EPIC showing her she was on PD. Serum creatinine was at 16 and went down and was low and stable for the sort of duration of this is a 2-year course here. So again, if you're only using serum creatinine, you'd think everything's doing fine with this kidney. But when we did our surveillance monitoring with TrueGraf, we said, okay, we're going to use TrueGraf to monitor her and avoid surveillance biopsies. We did that. So at month 6, we did our first TrueGraf test. We got a TX, which is a negative result. Everything's good. We move on to month 8, though, and we get a positive result, a not TX result. Okay, so we're not that excited about reversing this woman's Coumadin because that means coming in the hospital, bridging with heparin or low molecular weight heparin. So it's a complicated thing, as you know, to do a biopsy in someone who's on chronic, really needed constant anticoagulation. So what we decided to do is repeat the test in 4 weeks, and I'll show you data on the next slide as to why that can help us. Well, again, we had a positive result now 2 in a row. So we decided we should do a biopsy. So we admit her for a biopsy, bridge with heparin. We do a biopsy, and she, sure enough, has ongoing cellular rejection, borderline subclinical I1T1 rejection, DSA or negative. We treat her with pulse steroids. We increase her baseline immunosuppression, and we go on. So 3 months later, then we decide to repeat the TrueGraf, and she's still positive. And I'll show you some data that this can be used as a way to determine did we adequately treat the rejection. So there's the signs that we didn't. So that what did we do? So this is one of the hard parts now. Biomarker testing or surveillance biopsies are only one part of this. Right? You can get a result. The tricky thing then is knowing how and what to treat with. And we do this all the time when we look at our surveillance biopsies and our results. The same thing's true with biomarkers. In her case, we added low-dose sirolimus to the regimen, which is one thing we do. We're also now adding co-stimulatory blockade molecules in some cases. We added low-dose sirolimus, and we tested 2 months later, and she's back to a negative TX result. 3 months later, TX result. Good. She's doing fine, by the way. Creatinine's 1.2 to 1.5. She's feeling great. Everything else is good. And we're monitoring DSA, no new DSA. Month 20 comes around. She's back to a not TX. We realize her TAC levels have fallen a little bit, so we boost her levels up, and sure enough, then she flips back to TX 4 months later. Again, creatinine stable now at 2 years, no DSA. We've only done one biopsy in this early period. We've been able to avoid biopsies and manage her immunosuppression in an informed fashion to ideally prevent ongoing inflammation and graft fibrosis. So how does repeat testing work? This is some work we did looking at data from the CTOT-A trial where we did frequent blood sampling. And we looked at patients that we asked the question, okay, what if there was a positive result, a not TX? We looked at patients that had that. And remember, in the CTOT trial was an observational trial. So we just collected the samples. We didn't then develop the biomarker and come back to later. So these are patients that are just getting regular clinical care. We looked at those that had a not TX result. And then we looked at 1 month later and 2 months later because we had serial testing them. And we looked at the comparison of a person that had a positive test, then 2 negative tests, versus those that had a positive test followed by either a negative positive, positive negative, or 3 positives in a row. And we looked at their chances of going on to have an episode of clinical acute rejection, where we'd have a for-cause biopsy. And we looked at the odds ratio of that happening. And what we found is those that had 3 positive tests had a very high odds ratio of going on to have an episode of clinical acute rejection, statistically significant, although a small group. Those that had a positive, positive, negative had a more than double odds ratio, and those that had positive, negative, positive had a very high odds ratio, again, of going on to have subsequent rejection. So we think this is detecting ongoing inflammation, which can progress to worse rejection in the future. Okay. So not TX followed by a repeat not TX, either 4 or 8 weeks later, was associated with a higher odds ratio of rejection, meaning you probably should take that seriously and either biopsy that person or treat them, depending on the clinical scenario. Also, I point out from this case, recognizing early subclinical cellular rejection is half the battle. Knowing how to treat people is the other thing. Now, sometimes they have low MMF levels or they're not on steroids. You can add low-dose steroids, but some patients appear to be adequately immunosuppressed. And then the question is, of course, what to do, how to treat them safely, and how to prevent that ongoing inflammation. And this is where we get into truly personalized medicine. We were doing that with surveillance biopsies. Now we can approach that in a non-invasive fashion, and again, do it more frequently to better titrate our one therapy we truly deliver, which is immune suppression. Now, I talked about following up testing and knowing whether we treated rejection. So this is data. There's data to support this. Again, trying to stay where we have solid data to support this. From the CTOT-A trial, we designed the trial of patients that had subclinical rejection. So we took patients, everyone who had subclinical rejection based on a biopsy. And then we did what we call intense monitoring every 2 weeks. This is intense monitoring 2, 4, and 8 weeks later. And then after 8 weeks, we did another biopsy. Because again, these were stable patients with normal function with subclinical rejection. We wanted to know, did we adequately treat these people? And what we found was, despite routine standard of care treatment, less than half the patients with a follow-up biopsy had resolution of rejection. That was a surprising finding alone, because one thing we realize now is we're probably not adequately immunosuppressing some people who may need more immune suppression, or we decide to live with ongoing inflammation in the kidney and the subsequent sequelae of that, which we know can be increased risk of DSA, graft fibrosis, and worse function. But at any rate, so we did this, and what we found is after we went back, we looked at the group that had resolution of rejection here in red versus non-resolution in black here. And if we look at the biomarker with the positive negative threshold, we found that the group that had ongoing inflammation even 8 weeks later had a positive biomarker at the start and a positive biomarker at the end. So again, you would detect it. You can see a downward deflection in the gene expression, but it comes back up here. So we obviously didn't get it all here in these patients, and almost all of them have a positive biomarker 8 weeks later, telling us we should go back and retreat them or reconsider biopsying them or whatever. The good news is most of the people that had resolution of rejection had a negative biomarker at the end of the 8 weeks. Now, what's interesting also is about half of them would have had a negative biomarker to start with, which raises the question about whether histology, treating based on histology versus molecular biomarkers, is really the gold standard, and that's, of course, an ongoing debate. Another thing we looked at, and this is work in progress, it was presented at ASN most recently, we looked at 1,300 blood samples from patients in CTOT8 who had a subclinical rejection. This is the time of rejection here is at day 0 in both of these figures in the middle here. This is the gene expression profile score. So the gene expression score gives us a probability of rejection versus no rejection, and there's a cutoff. What we can see is that there's a very clear trend upward in the gene expression score here leading up to the time of rejection. And then when we treat the rejection, you can turn those genes off, and we see a good brisk downward slope here of the gene expression score. So that makes sense, right? So you're treating the rejection, you're turning off those genes that are causing inflammation, and that gets turned off. What we see with donor-derived cell-free DNA is a very different pattern here, and this is shown here. We see an increase again towards the time of rejection, which is a helpful thing as we see the scores going up. But then what we see is a continued upwards trajectory of the donor-derived cell-free DNA. So very different patterns of scores before and after a rejection episode. And of course, we're looking at more samples, and we're going to have more data coming on this shortly. But again, I think this is going to be really important, trying to figure out how do we manage patients using non-invasive testing before and after a time of rejection. Okay, next case is a case of pure AMR and a memory response. So typically when we think about rejection, we think about early allo recognition with the cellular response, which then sort of recruits the B cell compartment plasma cells, and we get a chronic antibody rejection. And of course, by the time we have antibody-mediated rejection, that's nowhere we want to be, because we know how hard it is to treat those patients. So we want to detect early cellular rejection and deal with it. Well, this is a case of someone who didn't have that because of pre-sensitization. So this is a case of a woman who got a kidney from her son, a living-related donor. Now, she had no pre-transplant DSA identified, but of course, with a living donor, we didn't have a long sort of tail of testing in her. We only had a couple samples to test for where we saw no DSA. So we went ahead and did the transplant, uneventful, did well. Immunosuppression was our standard tacrolimus and mycophenolate that was eventually converted to everolimus mycophenolate because of alopecia thought related to tacrolimus in the first year post-transplant. Again, an excellent course, did well. And we monitored this patient with TrueGraph to avoid surveillance biopsy. So at 3 and 12 months, where we normally do surveillance biopsies, we had TX results, didn't do a biopsy. We checked DSA at a year, no DSA. Again, graph doing fine, patient doing fine. We again do TrueGraph at 18 and 24 months when we typically do another biopsy. No DSA, negative TrueGraph, everything's good. So again, no DSA at that time point either. By 6 months later, we started the TrueLo registry trial, which, as you know, is monitoring OmniGraph, which is both the TrueGraph and the cell-free DNA with TRAC. And so we started doing that monitoring. We sent the first sample from the study, and we found, okay, a TX result with TrueGraph, but now the cell-free DNA is very elevated, almost 4.5%. Remember, 0.7% is the sort of cutoff for positive negative. So we said, well, this is really unexpected. So again, we repeated the OmniGraph a month later, and sure enough, TrueGraph still TX, but the TRAC is still elevated to almost the same level. So we went ahead and did a biopsy, and sure enough, we found acute subclinical antibody-mediated rejection with stable kidney function, but she had a G2 PTC2, so a lot of microvascular inflammation. She did have some tubulitis. C4D was strongly positive, no transplant glomerulopathy, no urine protein. So very early on, very subclinical. And now, remember, at 24 months, she had no DSA. Now, 6 months later, she has a new DSA against her son. This is a high class 1 HLA-C antibody and a low class 2 DQ. So, you know, with early AMR, we like to treat aggressively to try to prevent really significant injury here because she has no chronic score here at all. So we were going to keep this kidney healthy. So we treated her with steroids. We did plasmapheresis IVIG for the high level DSA. We gave her anti-CD20. We converted the everolimus back to a calcineurin inhibitor with cyclosporin, and then eventually have now transitioned to a belatacept low-dose cyclosporin mycophenolate prednisone regimen. Her cell-free DNA has trended down over time, not to normal. HLA-C antibody after 10 rounds of pheresis remained quite high, and that's not unexpected, but the DQ is currently undetectable. And again, her kidney function has been stable, and she's done well. So what are the takeaways here? Again, we think about sort of the immune response being a cellular and then antibody-mediated response typically. But in this case, we probably had an unrecognized memory response on the child-to-mother transplant that we didn't detect ahead of time. So again, cell-free DNA was better detecting the pure AMR case here compared to the gene expression. Now, gene expression picks up a lot of antibody-mediated rejection shown here, but it doesn't pick them all up, and that's where the combination therapy really is so helpful because you get the complementary value of testing. Okay, last case here I want to present is a case of a young woman, 30 years old, had a kidney transplant 10 years ago, had early cellular rejection in the first 2 years, treated successfully, in quotes. And again, this is the classic cellular response followed by an antibody response. She had stable kidney function for a long time, no urine protein, basically, UPC of 0.25, was on TAC MMF maintenance, says running low tacrolimus levels because of chronic warts, HPV-driven warts, and so was on a lower dose CNI for that reason, and again, was doing fine 10 years post-transplant. This is not an outrageous level to have at that point. She came in for an annual visit after she transferred from the pediatric hospital to our care and asked about, how's my transplant doing? Her creatinine had gone up a hair. It actually had hit 1.2 and then came back to 1.1, but that sort of got her attention. Said, well, how's my transplant doing? I said, well, the creatinine's stable, but again, that's not the whole story. So we sent the tests. We sent an omnigraph, and it came back that both were positive. TrueGraph was not TX, and the track was 4%. So knowing the high positive predictive value of both tests, we went straight to a biopsy, and we were very surprised to find very active chronic AMR, PTC2, G1, a lot of chronic glomerular damage, despite having almost no proteinuria and normal function. Not much tubular inflammation at all, but a lot of ongoing inflammation. And she had, again, probably not surprisingly, with an early cellular rejection, had strong DR and DQ antibodies, which had not been monitored in the interim before she transitioned to our care. So what do we do? This is, again, it's, these tools help us bring problems to light. It doesn't give us a solution to those problems. And that's sort of where we need the next level of clinical trials and testing. So we decided a couple things. We were worried about her warts, and we were working with dermatology. So we decided to transition her from MMF to a sirolimus and tacrolimus-based regimen. We added prednisone. We then decided, well, these are probably chronically elevated class 2 antibodies. We know those are very hard to deal with pheresis. They often don't really make much of a dent. So we decided to give her high-dose IVIG and anti-CD20. Well, the high-dose IVIG didn't work very well. She developed aseptic meningitis, and so that was sort of abandoned after one dose. We held further IVIG. We did give her anti-CD20. We monitored her with omnigraph during the treatment, and her track results stayed pretty elevated. In fact, they went up, and the TrueGraph remained not TX. And so this, again, with the data showing that after treatment, can you revert? And it was really suggesting we hadn't made a dent in the treatment. So at that point, we decided to add belatacept, alter a regimen a little bit, lower the CNI and the mTOR a little bit, add belatacept with prednisone. And then 3 months later, we see the TrueGraph had flipped back to a TX result, and track was trending downward. Creatinine remained stable at 1.2. UPC now has increased, possibly from reducing the calcineurin inhibitor exposure, a little more GFR, and maybe a higher pressure in the glomerulus and more proteinuria. But again, we know there's a lot of chronic glomerular damage in this case. So again, this is a tricky one because there aren't great solutions to the problem she has, although at least now we detected it and hopefully can make some interventions that will extend the graft life. So what are the takeaways here? When both TrueGraph and track are positive, there's very high PPV. I generally go straight to a biopsy without repeating because there's very high likelihood something's going on. I get asked a lot about the concordance between the two tests. Well, what if one's positive and one's negative? Is one right and one wrong? The answer is probably not. We now are learning about the pathophysiology these preferentially detect, and it may be that one test isn't validating the other test. It's more to do with underlying what's going on. So it's important to remember these are probably complementary, and so that's why it's good to use them together. So I think we've learned a lot about how we've used the test over the last 2 years. Hopefully these cases have been illustrative a little bit. I'm happy to take any questions about some of the things you've seen. Obviously, with any new tool like this, whether it's cell-free DNA, TrueGraph Track, or both, we're learning a lot with these as we use them in other case scenarios. Again, we want to make sure that we are sticking to the context, the proper context of use, where we know the cases, where we know the tests have been proven, and that's, again, in stable monitoring. Now, one question comes up, what about unstable patients? So I want to show you some data, again, from our CTAD trial. This was presented recently at the ASN by Suk Park, my colleague. And so we did look at, of course, we had for-cause biopsies in CTAD as well. And so we took those for-cause biopsies and looked at how do the two tests work together. This is a busy but similar table to what I showed you before. Here's the gene expression TrueGraph alone. Here's the cell-free DNA track alone. Here's the two tests together as one or other positive, or both negative or both positive. And what we found is a very high negative predictive value. When both tests are negative, you have an 88%, between 78 and 96% negative predictive value, and a good positive predictive value at 67% in the range here. What does that mean? That means if you have a person with graft dysfunction where you would do a for-cause biopsy, if you have both tests negative, you can be fairly certain that there's not much going on in that kidney. I'm going to show you the data on that in a second. Likewise, if you get positive tests, you probably should go ahead and do a biopsy because it's likely there's ongoing rejection and you probably need to figure out how to treat that. Remember, none of these tests, no molecular test has been shown to be able to tell you exactly what's going on in terms of BAF criteria. So really a biopsy still needed to decide how and what to treat. And again, of course, if to treat, and that can be, is there a lot of fibrosis? Is it really worth giving someone immunosuppressive therapy given the risk-benefit ratio? Now, talking about this in particular, when you've got a creatinine that's elevated, you really don't want to miss rejection. So what are the data on that? So this is the data from CTAD in those rejection samples. These are the clinical acute rejections, 20 cellular rejections pure, 20 AMRs, and 9 AMRs and 17 mixed. And this is the TrueGraph in green and the track in blue, so sort of same setup as the PRAST one. And a couple things are important to take home here. Number one is the test didn't miss any of the AMR alone. So it picked up all 9. Now in this case, TrueGraph was better. It picked up 7 of the AMRs. Track picked up 6 of the AMRs, and together they picked them all up. Likewise with the mixed rejections, we picked up all of them. There were no false negatives. So again, you can be fairly certain if both tests are done, you're not going to miss a significant rejection. Again, TrueGraph was better, picking up 15 of the rejections. Track picked up 10 of the rejections, but together they got them all. And then all they missed were 6 cellular rejections. 5 out of 6 of these were borderline rejections, and one was a 2A rejection, but it was only a V1 score with no other inflammation. So a very early vascular injury. So again, I think what the takeaway for me is here is that these work well in situations of graft dysfunction. You're not going to miss any significant rejections if you do them, and you can avoid biopsying a lot of people. What we found in CTAD-8 was, I don't show the data here, but of the for-cause biopsies, only a third had rejection. 2/3 of the biopsies done for cause showed no rejection. So that's a nice instance where you'll be able to avoid a biopsy in someone and probably monitor them or do some other testing. So that's the data. I'm happy to take any questions, and I really appreciate the invitation to speak today. Sorry we couldn't be at CIOT in person, but I look forward to seeing you hopefully at ATC in the future in person, and thanks so much for the invite.
Hi, everybody. Good morning, and thank you for joining us. Thank you very much for that presentation, Dr. Friedewald. So this is the Transplant Genomics Breakfast Symposium. So we have Dr. Friedewald as part of our Q&A, but we also have a couple others joining us. Dr. Mike Germain is here. He's a nephrologist at the Renal Transplant Associates of New England, associated with Bay State Medical Center. He's a fellow of American College of Physicians, and his major research interests include predictors of progressive loss of renal transplant function. I'll give him a few minutes to speak in a moment. And then lastly, I'd also like to introduce our relatively new Chief Medical Officer, Dr. John Friedman. He may be new to us, but many of you know him, I'm sure. He's been in transplant for over 20 years. He came to Transplant Genomics after spending about 21 years at Optum, where he was the CMO for their medical benefit management division, overseeing all complex condition management, but really focusing on CKD and end-stage renal disease and transplant. John was also co-founder of the United Health Group's HERO program, helping employees receive organs, which was awarded an NKF Corporate Innovation Award in 2021. He was instrumental in getting United Health Group to become the founding partner of the AST Corporate Circle of Excellence. And hopefully you guys heard him speak on Wednesday to the payer's perspective of a successful transplant. And I'll turn it over to John shortly. But Dr. Germain, would you like to say a few words with regards to your experiences with OmniGraph?
Sure. So it's always scary when I agree with another transplant nephrologist. It seems like there must be something wrong if we agree on almost everything. So, I mean, his presentation was awesome, and it's been our experience very similar to his. We're not a huge transplant program. We do about 50, 60 transplants a year, but we were earlier adopters of this technology. Like John, we started for 15, 20 years doing protocol biopsies every 3 months and a year. And we found that very useful. And so when this came along, we thought like, oh, this makes a lot of sense. We can do, a protocol biopsy, if you will, without doing a biopsy. And so we started with TrueGraph, but then as soon as TRAC became available, we started doing both tests together. And then when OmniGraph came out, we started right away doing OmniGraph in our patients. And again, we would do it at 3 months, 6 months, and a year. And we would repeat it based on the same kind of protocol that John would use. And the one thing that we have added to it is the molecular microscope. So when we do a biopsy based on an OmniGraph result, then we will also automatically do a molecular microscope. And I think that's incredibly valuable. And maybe it's our pathologist, but when I get the report back on a kidney biopsy, or if I look at it with the pathologist, it just makes me more confused than I started. And I just feel like it's always, well, it could be this, it could be that. And this is borderline, the dreaded word borderline. What the hell does that mean? And so now with a molecular microscope, it makes it much more precise what we're dealing with. And so the histology to me now is the least important thing that I put into the mix. And having 4 different variables, I think just absolutely increases your chance of getting the most accurate and like John says, the precision medicine and individualized medicine. I think that's the key, and that's what we're moving towards here, because we've always believed in individualized immunosuppression in our center. And so our experience has been very similar in our patients. We use it in the same way, except for now adding the molecular microscope and changing the immunosuppression. We've always been big adopters of belatacept from the beginning, from the trials. And so, especially for those that are developing DSAs, I think it's a real advantage because, of course, the data is that there are lower DSAs in the belatacept group from the randomized controlled trials. So I think we have a lot of options in these patients, and and you just don't want to kind of give up or just say, oh well, they have chronic rejection and there's nothing we can do about it. So I like John's last case where you say, oh, it's a couple of years out. Well, we're testing all our patients, even far out, and we do pick up cases just like this, like John picked up. And obviously we don't know prospectively if we're going to make an impact or improvement on graft survival in these people, but it's definitely worth a try with I think pretty low risk to the patient. Obviously the biggest risk is losing their kidney anyway and ending up back on dialysis. I had a question for John though. So how about using some of the quantitation that we don't get the results on for both the cell-free DNA? So for instance, not just percent, but looking at absolute cell-free DNA, donor-specific versus, the total cell-free DNA, and also the same for the TrueGraph, and looking more at quantitation, fine-tuning. It's good for a screen, but then when you have a problem patient and you're going to be following them serially, it would be nice to see the the quantitative values.
Yeah, good morning. Thank you. And again, thanks for everyone for joining. It's good to be here. That's a good question. So one of the questions comes up of, how do we get more information from this? And obviously we think that, initially we developed the test as a binary test with a threshold, but we realized that there is a probability score based on the gene expression profile that can, as I showed some of the data, track the response of the genes over time. And I do think it's going to be valuable. We're currently validating that. And again, we have always been very careful about saying this is where we have data, this is where we feel comfortable with the data, this is an appropriate context of use. And so as we develop the data with the tracking both not just the TrueGraph probability score, but also the cell-free DNA, the track score over time, and combining those two is what we're currently working on doing joint modeling for those. We hope to be able to come up with a more predictive indicator of when we think there's problems ahead and what we can do about that. And so, yeah, we're definitely working on that, and I think that will add value in the future. Patty's back. Okay.
Good. I'm glad you guys.
I was going to say there's some good questions in the chat we can start with. Yeah.
Yeah, let's start with the questions in the chat. I fell out and had to hop back in.
Well, I'll get to Raj's question. I see here the memory response is generally triggered in the early stages after the transplant, and asked the great question about in case 2 where we have the child to mother transplant. Why did it take 30 months post-transplant for that to happen? And I guess it's a good question. I don't have an easy answer to that. My response would be, I think that it probably has something to do with maintaining immunosuppression. And, as we get further out from the time of transplant and from induction, and as probably people get a little less compliant with or rigorous about taking their medicine twice a day. In this case, this person was on, 2 twice a day immunosuppressive medications, which we know, particularly in the evening doses, can lead to noncompliance. It may be that her net state of immunosuppression was decreased enough to allow that memory response to happen. So, I think about an early accelerated memory response and then a delayed memory response. And that's probably my best answer, but it's a good question because you're right. It wasn't an immediate thing. And we had DSA monitoring all the way up to the 2-year mark with nothing. And so you're right. Maybe that's the wrong term for it, but it was one in the absence of a typical cellular response, I guess is what I was trying to get into. Good question.
And then, John, I know Mike touched on the use of the biomarkers in patients further out from transplant, but that's another question in the chat. And I know you've had some experience with that, so wasn't sure if you would like to comment on your experience using them further out.
Yeah, when we first started using the test clinically, we tried again to stick to our initial data set, which was in the first couple of years post-transplant. But obviously, there's nothing magical about crossing the 24-month or the 36-month threshold. And so we have started to use them further out. Now, we don't use them as often, and typically I'm seeing patients on an annual basis, and I will check in and sort of see how their immunosuppression is doing with checking the OmniGraph and DSA. And so that's sort of our, annual, you get a health check on the kidney. How's the creatinine? How's the urine protein? What are the markers of graft health and graft longevity? And then how are we doing with immunosuppression? Not just the levels of immunosuppression drugs, but markers of are we adequately immunosuppressing? And that would be, OmniGraph looking at cell-free DNA, looking at gene expression, and then looking at DSA. So the whole package kind of gets us the idea of what's the graft health and how well is our immunosuppression actually working? And Michael made the great point that I think we detect these, there's no rule that you can't have rejection 6 years or 8 years post-transplant. And I think that we often think, well, they've had a good run and kidneys typically last 10 years. I think part of this whole CIOT is saying, wait a minute, we need to redefine success. And we need to not be complacent and say, oh yeah, 10 years is a good run and we'll retransplant. That's not what we're looking for anymore. At least I'm not. And so I think the idea that we can maintain adequate but safe immunosuppression for decades after transplant is really the goal. Until we come up with some better means of doing this, whether it's tolerance or something else. But I think that's really important. That's a take home. That's something I've learned along the way is that, wait a minute, we can't just say that the early people were worried about, the late people are fine and they'll probably be okay. Why not check in on them and why not make sure they're adequately and safely immunosuppressed? It's a question you can ask for the life of the transplant.
Yeah, I think there's a lot of, data that's come out now in terms of compliance and, even people who were compliant, I think John made this point, initially become less compliant as time goes on. And that's true of even, our best patients. And so, this is a way of picking that up. I mean, if you do this ongoing surveillance, you can pick up the fact that the patient's missing some doses and, not being as compliant as they were. And I think that will lead to, the beginning of, a rejection, whether it be acute or chronic, whether it be cellular or humoral. And then, you can catch it much earlier and then change your immunosuppression. So for instance, going back to belatacept, these people will definitely come in and not miss their belatacept doses, right? But they do forget, some of their oral doses during the day. So, this is, and also anytime you're taking a pill more than once a day, you're dramatically going to decrease your compliance. So there's a lot of things we can do in those patients to help them, get more sustained immunosuppression, whether it be, the monthly infusion of belatacept, taking a once a day tacrolimus, a lot of things like that can be helpful.
And I'll just, I see Bosma asked a great question. The follow-up is not just can we use these tests further out from transplant, but how do we interpret them and in the context of the levels and everything else? That's a good question. Some of our data and some data coming out of other studies as well has shown at least trends in cell-free DNA levels over time tend to, initially early post-transplant, they tend to be elevated with all the ischemia, reperfusion, and damage to the graft. And then that tends to settle out. But over time, they tend to trend slowly upward. And so I think it is important to realize that if you get an isolated level far post-transplant, it isn't always easiest to interpret in isolation. And I think that's where we put it in the context of all the other tests we have. Again, one of the take-homes I've had is that the way I use the test together is it really helps us think about pathophysiology. And again, I hate using just the word rejection because it's like using the word cancer. It's very nonspecific, and we need to be better as a field at identifying subphenotypes of rejection, just like they do with cancers, and get better at detecting them and then devising treatments. And we know this, right? We know a late severe AMR is much harder to treat than on 1-3 weeks post-transplant. And so we know clinically the phenotypes behave differently. We need to get better about defining them. And so with using the TrueGraph along with the track, you can kind of get a little more about what you think the underlying pathophysiology might be. Again, I still require a biopsy to treat in almost every case. And that's one of the questions in the chat is, can we get away from biopsies completely? I think we can get away from unnecessary surveillance biopsies, and that's, a lot. But I think in terms of knowing how and what to treat, I still think a biopsy at this point is necessary because there are other factors we think about. How much fibrosis is there? Is there other pathology in the kidney that requires adjusting the therapy a bit? So I think that's a key take-home point as well.
Yeah, there I might take a little bit of a different approach that, I think there really isn't good evidence that the histology is particularly either accurate or predictive. And also it doesn't really tell you how to manage the immunosuppression. And like John said, you don't really want to keep repeating it. And why repeat it if it's not that accurate anyway? So I noticed in one of John's cases, he did treat empirically. And, that's something I do a lot now too. I use the biopsy selectively and not in all cases. And I suppose, if you were just going to do a molecular microscope, you could probably get away with, maybe doing a much less invasive biopsy because, you don't need as much tissue. So that's something to think about in the future too, that, doing more of a fine needle or some other sort of biopsy, which is much, much less risky. And you'd get just enough tissue really to do molecular markers and not really worry about the histology, which is not all that awesome anyway.
Yeah, that's a fair point. I agree. And there are certainly cases where you get a positive test, you see an obvious, what seems to be an obvious problem with the net state of immunosuppression, and you can adjust that. I mean, we all see cases where, the one we saw a lot in the last 2 years, unfortunately, with people had COVID, and we would reduce in a proliferative or whatever it was, and then they're over it now, it's 2 months later, and what happens? And so they're obvious. Sometimes it's obvious. Yeah, we need to go back up on whatever it is. The hard cases are where you think they're optimally immunosuppressed, at least based on what we traditionally believe, and then you're still there.
Yeah. But I mean, if it's going to be humoral, then you can be monitoring the DSA, and then if whatever treatment you're giving for that, the DSA comes down, you feel pretty comfortable, and you don't really need a biopsy. And the same with if you think it's a cellular rejection, you give steroids and everything goes back to normal with the with the true graft, then you feel pretty comfortable too. So a lot of times you don't need the biopsy unless you're at equipoise and you're really not sure exactly what to do. And then you throw the biopsy and you get another piece of data.
That's right. Good point.
So another question that has popped up is related to, and I'm going to turn this over to John Friedman, is just related to kind of cost of the biomarkers and kind of value of care. And John, I know you gave an excellent presentation a couple of days ago on the value within healthcare, and just wondering if you had a question for our speakers.
Thanks, Patty. I really enjoyed the presentation, and John, I really appreciate what you just said about really looking for graft life that goes beyond 5 or 10 years. And I've always been value oriented, and the numerator to me is the patient getting one graft that lasts as long as the recipient's natural life. And the co-founder of the Cura program is a kidney recipient herself and is tired of getting her yearly surveillance biopsy. I don't think you'll find too many patients that say, gee, I can't wait to get my next biopsy. So the ability to earlier detect the subclinical rejection, hopefully leading to longer graft life with avoidance of retransplantation, and data that we presented previously that a lost graft in the first year is another $70,000 of medical expense, and graft loss in year 2 is $120,000 of expense. And returning to dialysis for a commercial payer is $280,000 a year of medical expense, which is $750,000 until they turn Medicare. And this really seems to me that the earlier we can detect, there's a tremendous lot of value that can be added to the system, both from the quality to the patient and the long-term total reduction and cost of care of these very challenging patients.
Yeah. Go ahead, Michael. Yeah.
No, I'm just going to say that's really, interesting approach, because, that's what we're looking at in CKD now with, shared savings models and, value-based care. So, the same can be applied to transplant. It's just that people have not really focused on that yet. But now we have the opportunity to do that. And, I think there are a lot of reasons to say that we could be penny wise and pound foolish. And, we could be thinking that, oh, this is an expensive test. Why are we doing this when we never had to use it before? Well, if like you say, you can extend the life of the graft even a year, you've saved, hundreds of thousands of dollars, really.
Yeah, I mean, I keep coming back to examples in the cancer field, because they do they've been doing things better than us for a little while, and we can learn from them. And I think one of them is the idea of screening. I mean, think about how cancer screening is done and why, because obviously catching a cancer early improves the chances of survival, but also reduces the cost of care. Some of the cases I present where we're giving anti-CD20 and plasma exchange and IVIG, those are really expensive treatments, not to mention they're not very successful. And so, like screening, I think as we think about, if we can detect early T-cell mediated rejection that's borderline, and everyone says, well, it doesn't matter, and what do I do with it? It's there, and we now have numerous. I think one of the nice things about the session I was part of the first day with Dr. Weeb and others, Roz Mann, the points were driven home that I think we need to all agree that T-cell mediated rejection is not a good thing, and if we can detect it and treat it, it's better than waiting until we have antibody mediated rejection. Just like you'd much rather detect a DCIS than a metastatic tumor. And so, if we can think about it and apply those principles to screening for the disease of rejection in our patients, and put it in remission and keep it in remission, and not have to wait for a late stage cancer or a late stage rejection that's hard to treat, unsuccessful to treat, costs a lot, all the things we don't want. And so I think that's really the approach we need to take, and not be afraid of, detecting early. Now, on the flip side, there's a great question in the chat about how we use these to minimize. And, we do focus a lot on the 25 to 35% or so of patients that'll have subclinical rejection in the first 2 years. That means 2/3 of people don't, and that's great. And we want to be also, we would like also to be able to apply this technology to benefit them. And the idea is that if they have quiescent biomarkers with no signs of inflammation, we should be able to start to back off on their immune suppression safely and use these biomarkers to do that in a safe and informed fashion, rather than saying we'll just wait until something terrible happens if we reduce your immune suppression. So I do want to make sure that we present both sides of the coin, because there's tremendous value, I think, in the other side of this, which is detecting immune quiescence reliably and using that to also personalize immunosuppression and reduce therapy. There's a lot of benefit to be had there too. And again, all these things, all the value that's given could be a long-term thing. It's not always a direct trade-off with the cost of a biopsy, the cost of the test we do in the first year. Think about screening for breast cancer, colon cancer. Those are expensive tests, but they pay off a lot in the long term, and we know that. And I think we can apply the same principles here.
John,
I was just going to say, in our program, you might think of it in the inverse way, because we've been a monotherapy program for a long time. And so, you could think of it in the inverse, and you start with, what you think you can get away with the least immunosuppression, and then you monitor, and then you change it based on that. That way you're not stuck with more immunosuppression than you need for a longer period of time.
Yeah, I think a bunch of different techniques will probably evolve with this, but I think the key now is we have some pretty good tools, non-invasive tools, to be able to do that. And that's what's so exciting. I mean, we're in a different era of transplantation now, and I think we need to embrace that, but we also need to maintain the momentum with the field, do the appropriate clinical trials to see how do we use these tools to really impact our patients' lives for the better. And I think that's what's so exciting about our current time.
So, John, you must have been reading my mind. So what type of clinical trials do you think we need to do in order to kind of help the IS optimization space?
Yeah, I think we need randomized trials of interventions using biomarkers versus no biomarkers. I think that's the first thing to prove the value. And I think that the challenge we all have in transplantation is with clinical trials is we tend to be fairly successful in the short term. And so it's hard to show differences. This has been the bane of new immunosuppressive drugs for a long time now, is, how do you show superiority when outcomes are pretty good in the short term? But I think we have some cool new tools to be able to do that with surrogate biomarkers. And so, the plan now is to develop a trial looking at a randomized trial of biomarkers versus no biomarkers with intervention, and both minimizing on one side and optimizing immunosuppression on the other side when we have positive or negative biomarkers, to really truly realize the personalized value of these tests.
Yeah, no, I agree. I think also, in the, post-rejection treatment space too, I think we could obviously learn more about how to best use the biomarkers to guide post-rejection, based on that data that came out of CTAD-8. I think that's
one of the things. I think, it's funny, in the old days, it was like, oh, they have stable creatinine, they're fine. And we forget, we just don't have to worry about that person. They're doing fine. I think the same thing holds true if we have negative and quiescent biomarkers. They may be fine, but in fact, some percentage of those people will be over-immunosuppressed and in danger to get an infection or get a malignancy. And I think that a call to arms is not to be complacent when we have immune quiescence, because that may mean over-immunosuppression. And so I think I'm really excited about how these markers will be used going forward to get, again, both sides of the coin, because a good number of our patients are quietly over-immunosuppressed, and we don't want to wait for clinical infections or clinical malignancies to happen before we can, in a subclinical manner, adjust immunosuppression safely for them too. So there's a lot of possibility here.
One of the immunosuppressive agent companies had this marketing thing about creatinine creep, and that always drove me crazy because creatinine creep means you've basically lost the kidney. So you can't wait for creatinine creep, not to mention the fact that creatinine is such an awful marker of GFR anyway. So a creeping creatinine means you're on the way to losing your kidney, and it's probably irreversible. So, now we have a much better way. We can look at omnigraph creep.
That's a great point. And that's so true. I think that we need to reset our mind frame a little bit about what we think is where we think we want to sort of keep patients in a safe zone. And that can be redefined using these biomarkers, again, to titrate our primary therapy, which is immunosuppression, and do it safely.
Yeah, no, it's an exciting time in the biomarker space. So hopefully good things to come this year. So are we almost out of time? I just don't want to. Yeah, I think we finished up right now. I think this was an hour, and I think we just hit the hour mark. I'm just looking in the chat to make sure, but let me just scan through the questions. I did see there was one from Vanita that I don't know that we answered.
I think we get another 15 minutes, Patty. We go to the bottom of the hour.
Okay, great. Thank you, John. Appreciate that.
But yeah, Vanita's question would be a good one to tackle.
Yeah. So Vanita's question was, in cases of relatively high risk, like case 2 of what John presented, shared mismatches with prior transplant, et cetera. In your experience, what is the recommended interval for track and gene expression monitoring in patients with otherwise stable renal function?
Yeah, I'll go
John?
first and I'll allow Michael too, but I think thanks, Vanita, and good to see you, and thanks for the comments. Always love your enthusiasm. I think that's a big question. That's an open question of what's the optimal timing and interval to do this. I think one thing is that, in a patient with a higher immunologic risk, we want to be monitoring probably more intensely and more early on. Because again, you want to catch the horse before it runs out of the barn. And so I think that in that case, earlier monitoring, the data in our trial starts at 1 month from the CTOD trial. And really the most data was at 3 months where we had our first surveillance biopsy. But we're seeing data from a month now. And I think that is probably a good a time as any to start. I think that the confounding problem of cell-free DNA in the early post-transplant period related to ischemia perfusion injury makes it a challenging thing to kind of read those tea leaves. But by a month, most of that is settled out, and you can start to use it as a more reliable marker of injury, particularly in a longitudinal fashion. So I think just like anything else, we probably will be more intense with some patients, and that probably means we can be less intensive with biomarker monitoring on other patients. And I know, our group and others are looking at, molecular mismatches and other ways to predict who needs more intensive monitoring. Maybe they need a surveillance biopsy on top of biomarkers. So I think we can really, again, get back to personalizing this care based on not just immunologic risk, but early, trends in biomarker results, et cetera. So I hope that answers your question. But typically we've been doing every 3 months, starting at month 3 out, so about 2 years, and then we will then space it out from there, depending on how the clinical course has gone, is my pat answer. But for certain patients, we may want to do it more frequently.
Yeah, I'm shocked at sometimes how early we see humoral rejection, even clinical humoral rejection, but certainly DSAs going up within weeks of the transplant, and not what you'd expect. And so, I think we need to move to earlier monitoring. And, I think people misunderstand and think the cell-free DNA is not going to be useful early on. And John's point is that, if you get a little ischemic injury with the transplant, but it's going to be relatively brief, and you could certainly also get a baseline. And if it's going down, then you're feeling good about it. If it's going up, you're not feeling good about it. And then, of course, with worse kidneys that we're getting now, we're seeing a lot more delayed graft function, and some of these people are remaining on dialysis, and then you have no idea, what's going on with the kidney. And we picked up a lot of people who, we thought, oh, it's just a bad kidney, and we'll wait. And then we do the biomarkers and we go, oh shit, there's a rejection going on. And then we biopsy and go, yeah, there's a rejection going on. It's all not just, delayed graft function from a bad kidney. And then of course, the combination of having a bad kidney and getting a rejection is not good. And you need to get on top of that right away. And furthermore, when you get a bad kidney, you're exposing the foreign antigens much more powerfully. than with a good kidney. So it's not unexpected that you might get more early rejection in a kidney that's not as good.
DGF. Yeah, that's a good point, and that's one to bring up is that I think that I would be less reliable. I think what's less reliable are the traditional cutoffs for positive, negative, but trends certainly could help you there in the early period. That's a great point. And I'll add the friendly amendment: all kidneys are good kidneys. Some are higher risk than others, and some have more delayed graft function. But every kidney is a good kidney if it gets someone off dialysis. But you're right, that just a friendly amendment. But I think that early inflammation with DGF is a real upregulator of antigen expression and a risk for early rejection. So you're right. Learning how to use these in that phase is going to be really important. And there's data coming on that.
Okay, I don't see any other questions in the chat. I think we've covered them all. John, did you have any other questions that you wanted to ask?
It keeps me thinking the whole concept of biopsy avoidance, and if you are potentially stretching context of use of cell-free DNA, are we going to actually have the slingshot effect of having more false positives, and that can be avoided through the use of gene expression and not have those biopsies that are showing up early on?
Yeah, I think one of the things I touched on in the presentation, but it's important to note, is that the improvement of the TrueGraph classifier in the move from microarray over to the microfluidics PCR platform, and that improved sensitivity really has driven down the number of false positives, which, again, if you're using the test as an avoidance of surveillance biopsies, you can avoid biopsying all the negatives. And if you end up doing a biopsy in someone with a false positive, you will do more biopsies than you otherwise could have, but still fewer than you would have done. But obviously no one wants to, have a false positive if we can avoid it. So that's one of the big advances of the PCR, not just the improved turnaround time, but also with the fewer false positives and fewer false negatives. And so that's a great point, John. I think that, again, using the two tests together in the newer version of the test with the PCR-based platform is going to be even better.
Plus it's only 6 mLs of blood.
Right. So yeah, and combine the ease of getting one tube and the amount of information you get with both tests is really quite helpful.
Yeah, and I think you just said it again, John. We're never going to do zero biopsies. Biopsies are a necessary evil in the management of kidney transplant patients, but you really want to make sure that when you're doing it, it's for high cause, and you're directed to be doing it, rather than randomly doing them where 75% will be negative, and lower the risk of getting a false positive.
Yeah, I think I sort of dream of a future where we don't need to be putting needles in kidneys, but that's still a ways off. I think we're working towards that for sure. Mm-hmm. It's going to take more data. One of the limitations we have in the field of transplant is we have, relatively small numbers of transplants, believe it or not, compared to cardiovascular trials where they enroll 100,000 people on a statin, for instance. And so it's going to take us longer to parse out these phenotypes, which are really important, but we will. The data are there. The molecular data is really quite powerful, and so we'll be able to get there with time and with enough good clinical trials.
John,
I think a good question. Sorry,
I'm going to ask you, a difficult question. Probably I shouldn't ask it, but comparing the different cell-free DNA tests out there, in some of our patients, we've gotten different tests, the same patient at the same time, different tests, and gotten different results. And, my head is kind of spinning from what I'm told about, the SNPs and all the different factors that different companies, tout in terms of their cell-free DNA tests. Could you provide some clarity on that?
So it's a good question, and the answer is no, I cannot, because I have not done head-to-head, comparisons with all of them. So no, I don't. In general, the technology is fairly similar, and the question is, with some mild differences in results that may be expected with any test. So no, I don't have head-to-head data on any of the 3 tests. I know there's some publications looking at comparisons between other 2 tests, but I don't have any data to compare the 3 at this point. And so I think that as the field moves towards standardization, I mean, look at creatinine, right? We were able to standardize creatinine because it is such an important marker, and there's a lot of effort that went into that. And I think, eventually maybe that'll occur, but at this point, I don't have any head-to-head data.
Yeah, there was a prospective study or looking at the 3 different tests, and they seem to perform fairly equally, but there was no, obviously because it was a big study, we didn't have granular information about the patients where there was discordance between the different tests. And so I think for the clinician out there, it's super confusing. And
well, I will say that the question I get about discordance comes up often between, TrueGraph and TRAC, and one's right and one's wrong. And the answer probably is we're detecting subtle differences in pathophysiology. And so, I get your point about the cell-free DNA products, but I think that I just wanted to make the point that, because I do get the question a lot of what if TrueGraph's positive and TRAC's negative, which one's right and which one's wrong? And I think the answer is, it's different tests. So
different tests, but the cell-free DNA, you would think they're similar, but then, you're getting different, results from the trials in those studies. And then as a clinician, if I use them together, I'm not infrequently getting discordant results. But, some of the companies are saying, cell-free DNA is not specific for humoral rejection and not even more specific for humoral rejection versus
So our data would suggest that cell-free DNA is positive. You can have elevated levels of cell-free DNA in patients with both cellular and antibody-mediated rejection. More often, it's detecting microvascular injury. So, you can actually look at a huge group of patients, and we can stratify by the PTC or the G score from the Banff criteria. And it tracks beautifully with, as you go from a PTC 0, 1, 2, 3 and a G 0, 1, 2, 3, the levels of cell-free DNA continually increase. And so, there is a pretty strong correlation with microvascular injury. Is it only that? No. Obviously it can be picked up from other cellular damage, so it depends on the type of injury to the kidney. I'm not surprised at all that there are slight differences between the different tests, but meaningful differences, I'm not sure whether that's true or not. And how clinically.
John, you did show that after the rejection, the cell-free DNA continues to go up, where the gene expression will invert and go back down to help show that you have hopefully successfully treated the episode, and you monitoring cell-free DNA is not going to do that by itself.
Yeah, at least in all patients for sure. Yeah. There's another big question that comes up about losing kidneys to cardiovascular disease and how can we reduce the chance of that? And I want to, as we are running out of time, answer that because I think it's a great question.
Yeah,
and I think that gets to the point of the other side of the coin, meaning if patients have negative biomarkers, we shouldn't just say, great. I think we should say, okay, maybe we can safely reduce immune suppression, because a lot of that burden of cardiovascular disease can come from the side effects and the unintended side effects of the immunosuppressive medications we take. Now, there are a lot of other traditional risk factors for cardiovascular disease, diabetes, high blood pressure. So managing those well is also very important, and those can be exacerbated by the immunosuppressive medications as well. But I think that it's a real opportunity we have to use these tests, not just to look for rejection, but also to look for quiescence and how we can safely reduce those drugs. So definitely, that's a very important question. And again, getting to the theme of the meeting, what is success? And the success is not having a heart attack or a stroke. And so, not just not having rejection in your kidney. And so that's a great point.
Yeah, no, Drew's question's great. Thank you for sending that in, Drew. And I think figuring out ways to use the biomarkers for what you would call immunosuppression optimization, obviously, that's ideally going to be minimization to get rid of those adverse effects from our
right. It could go up or down, right? Exactly.
Yeah. So, all right, you're nearing the end. Okay, sounds good. Yes. So, all right. Well, thank you, everyone. Really appreciate everyone listening in and all the great questions, and the interactive discussion between our presenters was excellent. So, thank you very much, everybody. And we hope you enjoy the rest of CIAT and hope to see you all soon at ATC.
Thanks, Patty and John. Thanks, everybody. Enjoy the meeting.
Thank you.
Thank you guys.